Hello, my name's Becky. I'm one of the palliative care consultants here at City and Sandwell Hospital, and today I'm going to give you a bit of an introduction to symptom control in palliative care and just a flavour of how we would approach a patient all around a case that I'll give you. So talking about symptom control, it's one of the main focuses of palliative care because we aim to maximise quality of life. But more than that, when we're talking about people who are even heading towards treatments for cancer, for example, maximising symptom control is important for maximising performance status and fitness for treatment going forwards. And the other thing that's important is that good symptom control is important throughout illness, so not just at the very end of life, but as the person goes through their treatments all through their disease course. So the case I'm going to talk about is a 54-year-old lady who has a diagnosis of pancreatic cancer with liver mets. She's been having some treatment with palliative gemcitabine chemotherapy, but unfortunately her disease progressed on that treatment, so it's been stopped. She's now presented to the hospital with nausea, confusion, some epigastric pain that radiates through to her back. She hasn't had her bowels open in 7 days. She normally takes for her pain 60 milligrams of MST twice a day with Oromorph 20 milligrams on a PRN basis. She also takes Creon, omeprazole and some ondansetron that her oncologist prescribed for her nausea. So the first thing to notice is the constellation of symptoms that she's presented with make me worry about hypercalcemia of malignancy. And that's really important because not only would we want to treat a hypercalcemia because it's a potentially treatable condition, but also it's key to symptom control. If we know that there's a constellation of symptoms that we could treat the cause of, then that would be preferable to giving separate drugs to treat the nausea, confusion, etc. So that's really important to pick up. As well as that, it's important to consider whether treatment of that condition would be what the patient wants. So it involves a discussion with the patient around what the goals of treatment are. So in this case, it would be IV fluids and then an IV bisphosphonate to treat the hypercalcemia, considering renal function when you give those drugs. So one of the symptoms that she presented with was nausea. Now, how we approach the management of nausea is firstly to identify the cause and then correct it if we can. Now, in this lady, we think that there might be a hypercalcemia, in which case we can treat that. But that doesn't mean that we ignore the symptom. We would treat that alongside. So we need to take a good history of the nausea and vomiting in order to establish what the cause might be. So is this just nausea? Is it nausea and vomiting, or is this purely vomiting? If you've got a good history of kind of emptying vomits that sound like they might be bowel obstruction, then that would guide your treatment in a very different way than if it were nausea related to chemotherapy treatments, for example. And then the antiemetic that we use is guided by what we establish the cause might be. So if we think this is a biochemical or drug-induced nausea, then we might use a drug like haloperidol. But if this is a gastric stasis type situation, then we would use a drug with some prokinetic action, something like metoclopramide or domperidone, for example. In the case of bowel obstruction, we may use antiemetics if there's a big nausea component. But if this is a person who is having big mechanical emptying vomits, and they feel relief of their nausea afterwards, then actually giving lots and lots of antiemetic will not make them feel any better. So in that case, it may be that they need none at all. And then in the case of someone with raised intracranial pressure and nausea related to that, we'd use a drug like cyclizine. Now, it may be that you start one antiemetic and that doesn't work, in which case we either have to switch to another, and in certain circumstances we add more than one drug together. It's also important to consider the route. So naturally we start with oral antiemetics if someone is feeling nauseated or vomiting. But actually if you've got a person who's vomiting a lot, they may not be able to keep those oral antiemetics down, in which case we need to think of an alternative route. So we could use the intravenous route, which you can be certain that the drug's getting into the system, but it does tend to give peaks and troughs in the symptom control. So often in palliative care, we might use a syringe driver in that circumstance, either as a temporary measure until we get control of the nausea or as a permanent feature if they need it. And once we've got control of the nausea and vomiting with the antiemetic in the syringe pump, we can switch back to oral medications if we can. And the other thing about starting a syringe pump in that circumstance to think about is that if you've got a patient that's on long-term opioid medications, you may need to put those in the pump with the antiemetic if they normally have that as a tablet, again, to make sure that they're getting their regular pain relief in their system. And especially in this case, we've got a lady who's come in with nausea and vomiting and worsening pain. Now, is that because the pain is worse, or is that because she's been unable to keep her regular morphine tablets down? And the other thing to consider with choosing antiemetics is any side effects that you might expect and any contraindications, and all the antiemetics come with an array of side effects, so it's just important to be aware of what they are when you're choosing. And there are certain circumstances, for example, patients with Parkinson's disease, where you would want to avoid any antidopaminergic drugs like metoclopramide and haloperidol. So the next symptom that she is complaining of is pain. So in the same way that we approach nausea in terms of taking a good assessment and trying to establish the cause, we would do exactly the same for pain. So we need a good assessment and a good history of what the pain is, because if we establish the cause, it might change what kind of treatments we gave for that pain, and also to consider whether we can relieve the cause of the pain. Pain can be of different types. So we have nociceptive pain, which is when there's actual tissue damage, or visceral pain, which is a type of nociceptive pain, but usually related to the abdominal viscera, and that's kind of a poorly localized pain. Or neuropathic pain, which tends to present more kind of with sharp burning pain, lancinating pain, and that's not due to actual tissue damage, it's due to damage to the nerves. So it's a false untrue signal of pain that's being told to the central nervous system. So pancreatic pain is interesting. It's notoriously hard to treat, and the reason is that it starts in the pancreas, but then as it progresses and as the tumour grows, it brings itself into close proximity to the celiac plexus, and that causes an intense neuropathic pain, and just in the way that this lady had described, starts epigastric and radiates through to the back. So we need to bear that in mind when we're choosing the pain relief agents. So we need to also consider the route, and I won't labour that point again because I mentioned before that she's not able to keep her oral medications down. Potentially we need to think of an alternative way to give her that pain relief. And if you have someone who's on long-term opioids, you must make sure that they get those regular opioids in one way or another. So when we're starting pain relief, we always give them regularly. If you've got a patient that's in pain all the time, there's no point giving them as and when required pain relief. They need something regular. And we also titrate their medications based on the World Health Organization analgesic ladder, which is basically that you start off with simple pain relief, like paracetamol, and then you escalate depending on what they need. So weak opioids first, like codeine and tramadol, and then the third step is strong opioids. But there's more than just that. It's important to bear in mind adjuvant analgesics, particularly important for neuropathic pain, like the lady that I've described. So we know in neuropathic pain, opioids definitely have their part, and for some patients that will be enough, but for a lot of patients they need the adjuvant analgesics to get control. So we're talking about non-steroidal drugs, antidepressants like amitriptyline, and anticonvulsants like gabapentin and pregabalin. And then on top of that, we have the option of interventional pain procedures that the pain anaesthetists offer. And in pancreatic pain, they can sometimes do a celiac plexus block. Now, this is not first line by any measure, but sometimes as we work our way through the drugs, we do start to think of these options. The other possibility that we need to bear in mind, not for this lady, but if you have someone with bone mets, that's another area where the pain is particularly hard to control. And in that instance, sometimes radiotherapy given by the oncologist can really help with the pain. And it's important to bear in mind that aside from the drugs, pain is a very complex phenomenon and it has higher inputs. So important that we think about the psychological aspects of the pain, the person's mood, Have we treated anxiety? Have we explored their spiritual needs, their existential distress, and also social factors that might be contributing? So it's by no means just the drugs when you're treating a pain. So the next symptom that we come to is the constipation. This is probably one of the most common things that we encounter in palliative care. I would say practically all the patients I see have some degree of constipation, and it's really multifactorial for most people. So we have a group of patients who are less mobile than they were, their diet has changed, and they're not drinking as well as they might be, and they're on lots of drugs that slow their gut down, so opioids, amitriptyline, all the drugs that we're talking about, ondansetron in particular, and this lady was on ondansetron for her nausea, and it's notoriously constipating. So it's important to be aware of these kind of side effects so that we can make sure we're getting the right medications for the patient. It's important again to take a good history of the constipation. So is this soft stool that the person's struggling to pass, in which case a stimulant laxative might help, or is this very hard stool that needs a softener like Docusate or Movicol? And it's important to consider whether the constipation's high up in the bowel or is it in the rectum, because if you've got a lot of constipation in the rectum, you might need rectal interventions such as an enema or suppositories. And the other thing that's really important when, if we were to see this lady in the hospital, is to make sure that we start to have open and honest conversations. We know that patients who have a more realistic expectation of what their quality of life would be and what their illness is presenting to them have better quality of life and better symptom control. If their expectations are too high, the quality of life that they perceive is lower. So it's important for lots of reasons that we have open and honest discussions about where the person is in their treatment journey, in their illness journey. And also that helps them to be able to make plans, to be able to express their wishes about what they would want for whatever time is left. And in order to plan realistically for the coming days, weeks, months. So kind of twofold, we need to treat the symptoms, but also make sure that the expectations of the patient are real. Just to mention for this patient, hypercalcemia is an interesting condition in the context of malignancy, and it's important when you're talking about future planning for this lady that she's in a position where she has no further treatment options for the cancer. She's progressed on chemotherapy, so there's no way to treat the underlying cause for the hypercalcemia. Unfortunately, we know that hypercalcemia carries a poor prognosis in itself, and it's highly likely to recur if we can't correct the underlying cause. So she needs to know that, because if she is not aware of the implications, she won't be able to make decisions about what she wants to happen should it arise again, which it's highly likely to. And unfortunately for a lot of people, when hypercalcemia does recur, treatments stop working or they work for a very short time, and that means unfortunately that person might be dying quite soon. So that's just a little snapshot of how we might approach a person in terms of managing their symptoms, and a little bit about kind of in the wider context of their illness. There's a lot more information out there, and I hope that you'll access it. So on the intranet at SWBH, there's some guidance on the Connected Palliative Care page, and there's a link on there also to the West Midlands Palliative Care Guidelines. So it's www.wmcares.org.uk, but you can Google that and it will bring it up, and you can go on there. And there's lots of information there about all the symptoms that we've discussed today and more.